try to better stage these patients. And so our hypothesis is that we could use CTC liquid biopsy to identify single cells or cells within patients with stage 3 melanoma, and that these should show up well before the standard imaging ever shows evidence of a relapse. So we tested our hypothesis by looking at the stage 3 patients who had radiologic evidence of recurrence with pathologic confirmation, and we saw how often that happened and how far in advance. So to really make this a stringent and well-controlled study, we tried to identify patients who had regular scanning. That was at least every 3 months, or I should say 3 months or every 6 months, with standard CT PET or CT cap. And then they had blood draws, baseline at the time of the stage 3 diagnosis. That's a pathologic diagnosis, and then 6-month and 12-month intervals. And then we followed them to look and see if there was evidence of recurrence. And I'm going to tell you that, because this is going to come up later, we considered even one cell a positive result. So even if you had one CTC, we called that positive. And I'll tell you why that is in just a second. So to find the cohort of patients we need, we found 359 from our prospective study, and we were able to identify 165 who met the criteria for having regular scans and regular blood draws. And you can see the breakdown there of positive and negative. And then there was another group who either had not relapsed yet. Remember, our median follow-up is 34 months, so this could still happen later. Or also, since a lot of patients travel to our center, some did not come back for follow-up scans. So we don't know when they recurred, even though we do know that a significant percentage of them had recurrence. We don't know when, because at some, we already saw the NCCN says 3 to 12 months. Some of them had to scan once a year. Some weren't even scanned. So we couldn't really include them in the study. So we're going to look at the 165 group on the left. And this is one of the problems when you're doing these liquid biopsies. You got a lot of things floating around in the bloodstream, right? So how are you going to identify the circulating tumor cells, which reside in that little buffy coat there with the leukocytes, okay? And you've got your plasma with your ctDNA. So how are you going to separate them? So we used a semi-automated system called Cell Search, which actually, the reason we chose this, it's been approved and used in breast cancer and is actually very easily assimilated into other institutions because it's a fairly standardized process. So we took 7.5 mils of blood, processed it within 72 hours, and then it's really not that complex of a system, because if you think about it, you've got all these things floating in the blood, but your platelets and red cells, they exude their nucleus when they're released into circulation, so they don't have a nucleus. So they're not going to stain with DAPI. So they're taken out because they're DAPI negative. So now you've got your white cells and your circulating tumor cells. Your white cells are negatively enriched or pulled out of the mix with anti-CD45 and 34. And so now you're left with a DAPI positive melanoma, high molecular weight, melanoma-associated antigen positive cell that's also CD146 or MCAM positive. And you can actually see those in that left column, and you can actually grade them and make sure it really looks like a metastasis. I'm sorry, like a cancer cell. And the reason we chose one cell is because in the past, we had actually published data based on just a baseline study showing that patients with stage 3 melanoma who have even one cell at baseline, that was associated with significantly higher rates of relapse. And again, so this is the reason for choosing one cell as positive. So this table is way too busy, and I don't want to, spend a lot of time on it, other than to say the important figures here are in red, and would be that not a lot of stage 3 patients, stage 3A patients were involved in the relapse group. There were very few local recurrences. You see, it's 3%. And also the staging modalities were pretty evenly spread out. And then also what's interesting is that 60% almost of the patients had a single circulating tumor cell, and about 11% had multiple 3 or more. The average number of draws was, the median number of blood draws was 3. And this is, I think, the most important slide. When you look at our number of patients who were positive, 76% of the patients, 125 of the 165, had at least one positive CTC result prior to radiographic identification and pathologic confirmation of relapse. Very few of these were local. In fact, only 3% were local relapse. So interestingly, the majority were distant metastasis, and the time between the positive result and positive imaging was 8.3 months. So this provides an interesting lead time, and we'll talk about that, what we could maybe do with that. Now, of course, this wasn't positive, perfect, right? So there were some patients who did not have CTCs detected, but who had positive imaging, and that was 40 patients, 24%. They had a slightly lower number of blood draws, so we may have missed one. It's possibly we missed a CTC. And also, interestingly, they had 5 times the number of local events. So it raises the question, is this a different biology? And maybe we're not picking up local, maybe it's a more lymphatic spread or local spread and not distant. But I don't think we have the answer yet. We should just say there were patients that had positive imaging that we weren't able to detect cells. And when we did a univariate analysis looking at the cohort of patients, again, way too busy, but I'm just going to point out the usual factors, the usual suspects are positive, like ulceration, Breslow thickness, number of lymph nodes, but also CTCs detected on any draw were predictive. And then when you get to your multivariate analysis, CTCs detected on any draw were independently associated with relapse. And so was the total number of lymph nodes with metastasis. So what's interesting is as the number of cells goes up, the hazard ratio increases, and the same thing happens with lymph nodes. And when we did our Kaplan-Meier analysis, you look at the patients who had positive imaging findings, and you can see the CTC positive, the blue line on the bottom, do significantly worse and relapsed. It was associated with earlier relapse. And then when we looked at the entire cohort, the same thing happens. And in fact, you see highly statistically significant. So really, I think showing there is true prognostic value in finding these cells in these patients at any time during their treatment course. I know we don't base treatments and changing practice on anecdotal, patient studies, but I just wanted to point out a few because I think they're somewhat illustrative. And if you look, here's a patient who is 3B at initial diagnosis, had no cells, developed a cell on a future draw, and then 9 months later has clear evidence of relapse, is placed on adjuvant therapy, and has no further positive cells and remains NED. You've got another patient here who's 3B, has cells identified 5 months before relapse, and then the patient is identified as positive on relapse, is put on single agent immunotherapy, but continues to produce more cells and actually shows progression on the next set of scans. And then you've got a combined case, which I put this one in because a lot of people ask, well, what's the deal with the ctDNA? Are is it useful? Can you use it? And I just want to point out, we haven't completed all of these yet, but I think it could be very complementary because here you see an example where a patient has no cells initially, yet has rising ctDNA, and then eventually the cells show up, but by then the ctDNA is quite high. And then the patient, literally, this is like, if you look at the beginning of when the ctDNA starts rising, it's more than a year before the scan shows the progression. And I'm just throwing this in because I think there is a future potentially in using both of these. When we look at the ctDNA, the values, so you actually, once we get above 8 nanograms per mil of ctDNA, almost all these patients, 93%, have relapsed. So to conclude, in the study we did, CTCs were identified in 76% of the patients who had positive imaging with pathologic confirmation of relapse, and it predated by 8.3 months. The presence of CTCs at any time was significantly and independently associated with relapse. Obviously, we're not going to be able to change practice with this, but I think it does really provide a basis for future studies where we can determine if CTCs and or ctDNA combined can better risk stratify melanoma patients, with the ultimate outcome being, could we potentially guide imaging? Maybe we don't need to order scans every 3 months. Could we save money because scans are certainly not inexpensive? And finally, could we eventually be able to actually use treatments? We need a predictive value for that. So for the future, we're doing a neoadjuvant study where we're taking the samples before, during, and after neoadjuvant immunotherapy to try to identify, can these agents remove the cells and potentially provide better outcome? So I didn't do all this work myself. Obviously, these are my collaborators and the funding. And I would just want to thank the Society for letting us present today.
Thank you for that excellent presentation. The discussion will be open by Dr. James Jacob from the Mayo Clinic.
Dr. Lucci, great work. Thanks again for sending me the manuscript in advance. You and your team continue to make progress in this space and advance the field of liquid biopsies and what I believe will be part of future clinical care. I was fortunate to be the invited discussion of your breast cancer work with circulating tumor cells at the 2015 Western Surgical meeting in Napa, and current circulating tumor cells are currently being used in the clinic in very select patients with breast cancer. I'm curious to hear where you think this is headed and how you see this eventually being incorporated into clinical care outside of clinical trials. My questions are all related. Number one, you demonstrated in many patients circulating tumor cells precede and are predictive of near-term future recurrence. Being predictive of a bad outcome and prognostic of treatment response are two different things. Do we have any suggestion that identifying these cells earlier will impact patients' overall survival? Number two, as we move forward to a more individualized approach to drug delivery and oncologic care, less and less of a shotgun approach and instead laser-focused targeted therapies, can detecting circulating tumor cells prompt an actionable treatment change in and of themselves? Or is there additional complementary biomarkers or imaging studies needed to direct therapy? And finally, as you demonstrated, circulating tumor cells and recurrence are not a one-to-one sum game. There are patients with circulating tumor cells who do not recur, and a very intriguing group of patients who cleared themselves of circulating tumor cells on their own without any treatment. There are also patients with no measurable circulating tumor cells who did recur. How do you see this being refined in the future to minimize potential under and over treatment based on the results? Thank you.
Thank you, Dr. Jacob. So to answer your first question, which I hope I will remember these in order, the first question relates to use and prognostic versus predictive value. And I think currently there's enough data to support prognostic significance for these cells. I mean, we've seen it in breast cancer. We know it's prognostically significant. We know in melanoma, I think this is our third publication on this to say there's prognostic significance. But the problem is we've done all this, but no one's going to use it, right? Because we don't have predictive benefit. So we're not going to use it to tell a patient, well, you're very likely to do worse, unless we know what we can do to improve the situation. So I think what we really need to do is test this in a prospective manner in a more controlled setting. One of the problems here that you brought up is that we actually did have patients that were receiving adjuvant immunotherapies, and we don't know, is that the reason they cleared the cells? Did their host immune system clear the cells? Or did we potentially just miss the cells in a future draw? Because, you know, this whole field, and especially when you're talking about these cells, the distribution is it's independent of a previous event. It's like we always talk about, it's like your mailbox. One day you have 5 letters, the next day you may have 1, one day you have none. If you catch it within this time period, you may identify them, you may not. So I think we need to do it in a more stringent manner where we're doing it before and after a treatment, and we can determine if that treatment is effective in removing the cells. Then potentially you could think about, and then it improves the outcome. Then you could think about using it in the clinic. Where I do think, and relating to your second question, where I do think it may become useful is if we could potentially combine these and increase our sensitivity and negative predictive value. It's right now about 67%, but I think you could get it even higher when you start talking about maybe with ctDNA at a non-detectable level. Then you could potentially avoid scanning patients. And if you think about that, it's a real hassle for the patients to come, you know, every 3 or 4 months to get CT scans, PET scan, they're injected with contrast. So you could think about instead, could you monitor them sequentially with CTCN or ctDNA, and then you have a trigger for when you need to image. And I think the cost savings, even though hypothetical, is quite significant. If you think about the cost of a PET scan, it's somewhere around, I think, $7,000 to $10,000. You're ordering, let's say, 4 of those a year, that's $40,000. We can currently do the blood test, this blood test, for about $350. That's about, what, $1,500 a year. So the cost savings is immense. When you add in ctDNA, you're obviously going to add in more expense, but I still think it'll be a lot cheaper and better for the patients than having multiple scans per year. And I don't remember, what was your last question again? Sorry.
In terms of circulating tumor cells, can they give you a target to treat?
That's great. I'm sorry. And so that's a really important point. You can actually identify unique markers on CTCs. Being a whole cell, you can identify markers. So there's already data, and we've already seen some evidence that we now measure PD-L1 because on CTCs, because there's we've already seen that CTC PD-L1 may actually be predictive of response to pembrolizumab. So you can actually use that. But I think the other thing we're looking at, and I think we may have seen it in one of those last slides, is when we're using the ctDNA, we'll notice new mutations showing up and even potentially targetable mutations. That's where I think the combination really would come in, because you could theoretically identify targetable mutations. And though a single target may not suffice, you may look at like lung cancer, for instance, EGFR. So I think it is possible. And I think the future would hold that we really could use this as a way to guide therapy. We're not there yet, obviously, but I think that's our goal.
I have a question. That was a great talk. This concept of a biomarker in the blood is starting to spread throughout other malignancies. Well, I know that in the community, some of the oncologists in our area are even starting to make some treatment decisions based off this for minimal residual disease, even for colon cancer. How do you use this technology and temper that before it's proven to be helpful? Thanks.
Yeah, I think that's a great question. So what we've done is we've actually worked with a lot of our colleagues at our institution. I know we've already actually looked into this in colon cancer, rectal cancer, pancreatic cancer. I think Dr. Sang and his group has already published some data on that, comparing peripheral versus portal vein blood sampling. We're looking at it in metastatic thyroid cancer. So we've actually looked at it in a lot of different settings. And I think your point is a really good one. It's not really ready yet because we simply don't know what we would do to change treatment. And I think that's the problem is some oncologists may, even if we gave them this information, what would they do? Would they have added a second agent, let's say for the patient who's on single agent nivolumab, but increasing the number of cells and ctDNA? Would they actually put them on combination therapy? I think that's the unknown, and that's what we have to find out from future studies. And if it turns out that it works, that's fantastic. I just think we're not there yet. I could also point out, look at breast cancer, where the SWOG study looked at, does chemotherapy eradicate these cells? And it did not. And so that's one of the reasons it's not used to guide treatment. We just don't know what gets rid of them. So I think it needs to be proven before it can be used in the clinic.
Dr. Jamir.
Hi, Mike Demur, Newport Beach. I think it's really great. I mean, there's tons of biomarkers, obviously, and exosomes, circulating DNA, all these. We don't know where they're all going to sort out, but I wonder if you would speculate on using it to sort of either guide finishing adjuvant therapy. So somebody's getting therapy and you say, okay, now you've cleared your circulating tumor DNA. Instead of giving somebody 2 years of immunotherapy, they could get 7 months because they've cleared their circulating tumor markers. Something and individualizing cessation of adjuvant therapy, or even looking to see if a tumor is responding by somebody being treated and then the circulating markers are decreasing versus increasing, and the idea of sort of the tumor markers are increasing on therapy, so they're not effective, distinguishing progression from pseudo progression on immunotherapy, for example.
Those are all great points. And I think pseudo progression, for instance, it's a really great point. You don't know sometimes on the imaging, do you actually have response or not? So you could potentially use blood-based biomarkers as a way to help you figure that out. And I think you also bring up cessation of therapy. If a patient, let's say, gets to the point where they have no non-detectable ctDNA, no cells, could you then stop therapy and potentially avoid the morbidity of extended therapy? I think those are all things that we need to look at. We're trying to do that now in this neoadjuvant protocol because I think it's a lot better controlled, where we have known agents and known sampling points, and we can then see, are we actually eliciting a change before and after the therapy? And by the way, it's a great point because we're getting scans in the middle of therapy, so it would be really interesting to see which is performing better, the scan or the blood-based therapy. And I'll be really curious to see, how that turns out.
Thank you, Dr. Lucci. Excellent paper. Congratulations.
Thank you.
Our next paper is breast cancer recurrence by subtype in a diverse contemporary cohort of young women, presented by Dr. Brooke Fong from Kaiser Permanente South Sacramento Medical Center. And this is an Oust Award candidate paper.
Thank you for the program committee for the privilege of the podium. I will be presenting the outcomes and treatments for young breast cancer. I have no disclosures, except for the fact that I have tested 4 times and it's not COVID. Let's see. Great. But let's hope my voice can hold up. So sorry. Okay, so according to the American Cancer Society, there are 1,230 new cases of DCIS and 10,850 cases of invasive breast cancer diagnosed annually in women under the age of 40. We know that 1 in 8 women will be diagnosed with breast cancer in their lifetime, but by age 40, 1 in 63 women will be diagnosed and 1 in 674 women will die from breast cancer. Young breast cancer patients face unique issues. They have increased likelihood of germline cancer mutations and more aggressive disease biology with a higher proportion of HER2 enriched and triple negative subtypes. They also present at higher stages, likely because there's no standard screening for this age group and who often present with a palpable mass. The fear of recurrence can lead these young patients to opt for more extensive surgery and lead to possible decisional regret. There's also a potential bias for overtreatment with higher mastectomy rates and high rates of chemotherapy, and these can have long-lasting effects. Treatment adherence to chemotherapy and/or endocrine therapy can be a trade-off for young women, given the impact on fertility and early menopause. And in addition, many patients undergo multimodal treatment, leading to medical leave and financial hardship during their peak earning years. So the aim of our study is to characterize the young breast cancer patient population, evaluate treatment patterns, and determine recurrence rate by subtype. Female patients age 40 and under diagnosed with stage 0 to 3 breast cancer from 2008 to 2018 were included. We performed a retrospective review of prospectively collected data for patients who were treated in Kaiser Permanente, Northern California. TPMG has approximately 4.5 million members and includes 21 medical centers, and our primary outcome was recurrence. There are 1,564 women under the age of 40, stage 0 to 3 breast cancer. 13.5% of those present with DCIS and 86.5% presented with invasive cancer, with a mean follow-up of 5.5 years. The study population was ethnically diverse. The majority of patients included were people of color. Approximately 30% of the population was Asian Pacific Islander, nearly 20% Hispanic, and 8% African American. And one of the critiques of clinical trials is a lack of ethnic diversity of enrolled patients. I will briefly review the outcomes for DCIS. The median age was 39 years. 87% were hormone receptor positive, and the majority underwent a mastectomy. 6.7% of the patients with DCIS recurred, and most of these were local regional recurrences. There was no difference in recurrence by hormone receptor status for DCIS patients. So the remainder of our talk is going to focus on our young patients with invasive breast cancer. So on the left is a 2022 American Cancer Society facts and figures published of the subtype distributions across all age groups. And on the right is a population of each subtype for this particular cohort. So in this cohort, 25% were HER2 positive compared to 14% in a general population. There were 18% of women with triple negative disease compared to 10% in a general population. And 19% of our hormone receptor positive patients were grade 3. Our final invasive breast cancer cohort included 1,431 women age 40 and under. The median age at diagnosis was 37, the mean BMI was 26, and there was no statistically significant difference in socioeconomic status or comorbidities. 64% of patients presented with stage 2 and stage 3 disease. Nearly half of the tumors were grade 3, and the highest proportion of high-grade tumors were in the triple negative subtype. Laterality was evenly distributed, only 1.7 presented with bilateral disease, and the vast majority, 85%, presented with ductal histology. There were 254 women who underwent oncotype testing. 61% of the hormone receptor positive grade 3 tumors tested had a score of greater than 25, denoting a higher risk of recurrence. 2/3 of the patients underwent a mastectomy, and there was no statistically significant difference in breast conservation rate among the 5 subtypes. 52% of patients underwent immediate reconstruction, and 19% had delayed reconstruction. 19% of patients had delayed reconstruction. 35% of women underwent a contralateral mastectomy, and there was no difference based on tumor subtype. 85.7% of the patients in our cohort underwent germline testing, 17.2% had a pathogenic mutation. 12% tested positive for BRCA1 or BRCA2, and BRCA2 mutations were frequently seen in the hormone receptor positive HER2 negative tumors, whereas BRCA1 mutations were seen in triple negative tumors. The overall genetic mutation rate was highest in patients with triple negative breast cancer. We then reviewed adjuvant therapy by subtype. 80% of patients received chemotherapy, and over 90% of patients with HER2 positive disease received HER2 targeted therapy. 18.5% of patients received neoadjuvant chemotherapy, and the highest rates of neoadjuvant chemotherapy were seen in HER2 positive and triple negative disease. Of the 1,071 patients who were hormone receptor positive, 89.6% filled at least one prescription for endocrine therapy, and that includes either tamoxifen or an aromatase inhibitor. So the proportion of women with recurrences did vary by subtype. And I think of this as like my take-home slide, but high-grade hormone receptor positive, HER2 negative, or HER2 enriched cancers have the highest proportion of recurrences, both with over a 20% rate of recurrence. The median time to recurrence also varied by subtype. HER2 enriched and triple negative cancers had the shortest time to recurrence, both within the first 2 years. 16% of patients had a recurrence during follow-up. That's our overall recurrence rate. But of these, 74% of the recurrences were distant. And local regional only recurrence was seen in 3.7% of the patients who underwent a lumpectomy versus 4.2% of patients undergoing a mastectomy. So in conclusion, by age 40, 1 in 63 women will be diagnosed with breast cancer. They often present with a higher stage and a more aggressive subtype. 2/3 underwent a mastectomy and 35% had a contralateral prophylactic mastectomy. There was a 16.1% recurrence rate, highest in hormone receptor positive HER2 negative grade 3 and HER2 enriched tumors. And there was a shorter time to recurrence in HER2 enriched and triple negative tumors. The strengths of this study was that it's in a large contemporary cohort of young breast cancer patients. And we have detailed information regarding recurrence in a closed system. We also have close follow-up. And this population was ethnically and socioeconomically diverse. The limitations is that it was retrospective, and we did have to go through, during this time period, 3 AJCC staging manuals, and recommendations for breast cancer changed over time. So now that we've built this cohort, our future projects, we're looking at the predictors of recurrence. And then we also want to look at the utilization of neoadjuvant chemotherapy over time and evaluate the outcomes based on their pathologic complete response. And then we want to study the outcomes of women who elect for breast conservation with a pathogenic germline mutation. Thank you, and I'm willing to take any questions.
Congratulations on that excellently presented paper, despite your upper respiratory issues. Our first invited discussant is Dr. Catherine Yao from North Shore University.
I would like to thank the Western for giving me the opportunity to discuss this paper and thank the authors for giving me the manuscript ahead of time. Vong et al. Have written a nice manuscript on 1,400 women under 40 with newly diagnosed breast cancer. As several studies have shown, these women have worse prognosis and face unique challenges, such as fertility, pregnancy, how to care for young children while undergoing treatment. This cohort of patients are ethnically diverse, and there was a lot of variability in the recurrence rates by tumor phenotype. But we did see that the type of surgery, i.e. breast conservation or mastectomy, was not associated with outcomes. I have several questions. A unique feature of your data set is that 85% had genetic testing. Was this testing done at the time of diagnosis, or had it already been done by the time the patients were diagnosed? And did you analyze type of surgery stratified by genetic mutation status, or local recurrence or distant recurrence? Your study does go from 2008 to 2018. Did you look at any trends in the recurrence risks? Were they improving over time, or trends in the use of neoadjuvant therapy? Did those change over time? Do you have any information on whether patients became pregnant during or after treatment? Some studies have suggested better outcomes for those patients who become pregnant after treatment. Many of the treatment regimens over your time period of your study have changed quite dramatically: ovarian suppression, adjuvant, neoadjuvant therapies. And could you comment on how those might impact the outcomes of these young women, particularly ovarian suppression? The hormone receptor negative HER2 positive subtype had the highest path CR rates in your study, but also the highest recurrence risks and the worst mortality. Somewhat surprising, given that several studies have shown that path CR is associated with improved prognosis. Do we think that path CR may mean something different in younger women? 254 women had oncotype testing. And I'm curious to know how the clinicians use this information to make decisions. Were they willing to forego adjuvant chemotherapy if there was a low oncotype score, given that this is such a young patient population? And that's all I have. Thank you very much.
Great, thank you. Well, may kind of try to go through these systematically. So first was well, I'm going to go backwards. The oncotype question that you brought up is a very good question. And so we did parcel out a subset of T1 to T2 and 0 breast cancers and look at the utilization of chemotherapy before or if they had an oncotype test and if they didn't. And we also looked at our utilization of oncotype testing across each year. And so that will be presented at the San Antonio Breast Conference. But in short, T1 and 0s, I think people are more inclined to follow the biology, and T2 and 0s, I think there's a bias that these patients might need adjuvant systemic treatment. And so it is a smaller cohort, as our cohort ended at 2018. And Taylor X was also published around that time, but we had been enrolling into these trials and we're utilizing oncotype for a lot of this period. So I think that's an excellent question. To go back to, there's several questions, Dr. Alfie. Looking at their use of neoadjuvant chemotherapy over time. So I did run that, and the 6% at the beginning of the time period were receiving neoadjuvant chemotherapy, and 15 to 17% were receiving neoadjuvant chemotherapy by the end of the time period. So we do see an increased utilization of neoadjuvant chemotherapy, and I think that has a large contribution due to Catherine being published in 2019, Create X in 2018, showing us that the response to neoadjuvant treatment can guide our adjuvant therapies. And again, while these weren't published, we were enrolling for these trials. And so our practice sort of modified according to this for some of these patients. So I think, and I did not present a pathologic complete response here, and I did reserve that for the manuscript. And that nuance you brought up is very interesting, that the high responders with a PCR were also the same subset who had a high recurrence. And so I think we have a lot of literature out there that varies as far as like what the significance is of a pathologic complete response and whether that can be a good clinical outcome for us to follow. So I do think, I echo what you're saying. I think it's not so clean to say if someone had a PCR that they're going to have an excellent outcome. I think that's much more nuanced, and maybe it is more nuanced in this young population. And if you don't mind, the first couple questions were
The genetic testing.
Oh yeah, so genetic testing. That is an excellent question. So the patients are offered genetic testing at the time of their diagnosis by our breast care coordinators, but they may or may not have the result by the time they made a decision to undergo their surgery. Some may elect to wait for their results, but others may not. We do try to get our patients in within 2 weeks of their diagnosis to their first treatment. So that's a metric we have. It's not everyone's perfect, and some want all of that information before making that decision. So to answer that question, we don't have the date of their result and then the timing of their first treatment. I'm sure we can extrapolate that, but we do offer everything, which I think is why we have such a high adoption of genetic testing in our system. So, and I really, as a practicing surgeon who does breast cancer surgery, I think women do ask, like, if I'm positive, can I undergo breast conservation? And so I think that's an important question that you've brought up too, is whether, what are their outcomes if they elect to do this, and what is their risk of recurrence? So we will be looking into that further.
And then the last question about pregnancy, did any woman become pregnant?
So interestingly enough, I did go back to our analyst, and in looking for BMI, she was able to pull all the pregnant people because she's an excellent analyst. So it's to see what their BMI was, that if they happened to be pregnant at the time. So she has been able to pull this cohort, not in time to run for this meeting, but I think it's an important question on the protective value of pregnancy and what the outcomes will be like. And so we will probably have that cohort available to analyze and look into. Lastly, actually, you brought up ovarian suppression, and I think the limitations of this study is that we were able to look at who filled a prescription, but not necessarily their adherence. And so the trials you're alluding to, Atlas and SOFT, and the length of endocrine therapy, we did not look at adherence and if they were on an extended course, and more so whether they filled it or not. And I was even impressed that, over 85% filled a prescription for endocrine therapy, given the side effects in this population. Thank you so much for your comments.
Great. The discussion will be continued by Dr. Johnson.
Thank you. Very, very nicely presented work. And I just have a couple questions. One is you showed that a large number of your early or women who were under 40 with diagnosis were ethnically diverse. And so I wonder how that informs your screening of that patient population and how you guys screen. In addition to the question on genetic testing, how good a job are you guys doing at catching these groups of women that are higher risk for carrying a mutation? And then my second question is, it looked like you overwhelmingly used Oncotype DX, and there's some big data. Dr. Hoskins and his group published that Oncotype DX is probably not accurate in African-American women. And so you see a higher death rate in low risk node negative African-American women. And are you guys using that, or have you looked at that in your patient population to see whether you have higher recurrences, and maybe MammaPrint may be a more accurate study to use for Black women who are under 40, or Black women in general? Thank you.
Great, thank you. Those are both excellent points. In regards to your second question, one of the reasons I wanted to look at this population is because they often are underrepresented in these large clinical trials. So TAILOR-X had less than 4% of women were under the age of 40. And MIND-ACT, I think, had 6.2% who were under the age of 40. So we extrapolate a lot, whether it's young patients or African-American patients. And that's how I kind of touched briefly on the lack of ethnic diversity in these clinical trials. So we often apply them broadly. But I think you really have brought up an important point that maybe there are more appropriate tests for certain subpopulations. And I will definitely take that back to our institution. Thank you.
Great. One last quick question from Dr. Hansen.
Yeah, I had a quick question. In terms of your mastectomy rate was much higher than your conservation rate, but the recurrence rate were no different. How are we going to convince our patients not to proceed with mastectomy in the future? And the other quick question is, well, I forgot my other question. That's my question. Thanks.
I think you asked the exact question that we deal with nearly on every new diagnosis patient on our consultations. One, we saw a contralateral mastectomy rate that was higher than our positive genetic mutation rate. So that already tells you that patients are probably surgically overtreating their disease. But I think this is precisely why I wanted to look at this population. And when we can show them that most of these recurrences are distant if they were to recur. And so their surgery type does, and there we know in the field that we have many landmark trials that show there's no difference in breast conservation and mastectomy. But these are young patients who are scared and nervous, and recurrence means a lot to them. It's a meaningful outcome. They're afraid their next, one day they'll feel something else, or when's their next cancer. And so I just think, and I have, used some of this data to tell them, like, these recurrences are often distant, and those are the recurrences we really care about, and I often joke, and I always take out your breast, but I can't put it back in. And I jest that way because I want them to understand that they're making these decisions, some out of fear, some because maybe they didn't risk stratify being genetically positive and have a family history, or they just want to do everything they can possibly do. So I think we address all of those in our consultations, but I think having data here showing that the recurrences are more often distant, and it's not the primary surgery that affects it, and that's across all subtypes.
Great. Thank you so much for an excellent presentation.
Congratulations.
Our final paper of this session is a time to whole blood transfusion in hemorrhaging civilian trauma patients. There is always room for improvement. The presenter, and please correct me if I pronounce your name wrong, Dr. Hamidreza Husseinpour from University of Arizona.
Thank you.
Sort of.
Yeah.
Okay.
Good morning. My name is Hamid. I'm a postdoc research fellow at University of Arizona. I'd like to thank Western Surgical Association Committee for providing us the opportunity to present our study. I have no disclosure. Hemorrhage is responsible for 40% of civilian and up to 90% of military-related trauma mortality. And despite the advancement in resuscitation strategies, it remains the leading cause of early mortality among trauma patients. Looking at the literature during the last decade, multiple high-level studies evaluated the effect of whole blood as an adjunct to component therapy on the outcomes of bleeding trauma patients. And they found that the use of whole blood is associated with decreased mortality, major complications, hospital length of stay, and transfusion requirements. However, none of these studies reported time to whole blood transfusion. Despite previously mentioned studies that they were designed to give whole blood as early as possible to the patients, when we look at the time to receive whole blood in trauma centers across the United States, we realize that there is a lot of variation in time to whole blood transfusion, with most of the patients receiving whole blood within the first 2 hours of admission. And there is a lack of data on describing the effect of time to whole blood transfusion on outcomes of bleeding trauma patients. So the aim of our study was to assess the impact of timing of whole blood transfusion on the outcomes of civilian trauma patients. And we hypothesized that earlier whole blood would be associated with improved outcomes. To answer our question, we performed a 3-year retrospective analysis of American College of Surgeons Trauma Quality Improvement Program database. We included adult trauma patients aged more than equal 18 years old who received whole blood within the first 2 hours of ED arrival, and excluded patients with severe TBI, which was defined as head AIS more than equal 3, transferred patients, and those who had missing information pertaining to time to whole blood transfusion. We stratified patients based on the time to first unit of whole blood transfusion into 2 groups, first hour and second hour. And then we substratified the first hour group into first and second 30 minutes. Our primary outcome were 24-hour and in-hospital mortality, and the secondary outcome were major complications and hospital and ICU length of stay. And we performed the following statistical analysis. For our multivariable regression analysis, we controlled for patients' demographic, admission vitals, transport time and mode, injury characteristics, comorbidities, in-hospital procedures, blood product requirements, and time to PRBC transfusion and hemorrhage control surgeries, and also the ACS verification level of trauma centers that these patients were treated at. Among nearly 2,000 trauma patients who received whole blood within the first 2 hours of ED arrival, 87% of the patient had whole blood within the first hour, out of which 81% of the patients received whole blood within the first 30 minutes. Comparing the baseline characteristics of these 3 groups, patients who received whole blood within the first 30 minutes were more likely to be younger, male, and had higher shock index and lower GCS. Regarding the injury characteristics, all these 3 groups had comparable injury severity scores and body region specific AIS scores. However, looking at the mechanism of injury, patients in the first 30-minute group were more likely to suffer from penetrating injury and less likely to suffer from MVC and fall injuries. Looking at the peri-hospital characteristics, patients in the first 30-minute group were more likely to experience peri-hospital cardiac arrest. However, there was no statistically significant difference in terms of transport mode and time. Overall, there was no statistical significant difference among these 3 groups in terms of ACS verification level of treating trauma center, comorbidities, and 4-hour blood product transfusion requirements. So first, we compared the outcomes of patients who received whole blood within the first hour of ED arrival and those who received whole blood within the second hour of ED arrival. On multivariable regression analysis, we found that patients who received whole blood within the second hour of admission were twice more likely to develop major complications, including acute kidney injury and unplanned return to OR, and had significantly longer hospital and ICU length of stay. Comparing the outcomes of first and second 30-minute group, on multivariable regression analysis, we found that patients who received whole blood within the second 30 minutes had significantly higher adjusted odds of 24-hour and in-hospital mortality and had significantly longer hospital length of stay. Then we identified 905 patients who received whole blood within the first 2 hours of admission and had shock index of more than 1. This figure demonstrates the results of our multivariable regression analysis. The dark blue bars are indicator of 24-hour mortality, and the yellow bars are indicator of in-hospital mortality. As you see, after controlling for confounding factors, every 30-minute delay in whole blood transfusion was associated with higher risk-adjusted odds of 24-hour and in-hospital mortality. In fact, the last group had 3 times higher adjusted odds of 24-hour and in-hospital mortality compared to patients who received whole blood within the first 30 minutes of admission. All these findings made us to perform another sub-analysis on patients who received whole blood within the first hour of ED arrival and had a shock index of more than 1. In this case, we found that every minute delay in whole blood transfusion was associated with increased odds of 24-hour and in-hospital mortality. In conclusion, every minute delay in receiving whole blood is associated with 2% increase in risk-adjusted odds of 24-hour and in-hospital mortality among hemorrhagic trauma patients. Notably, the decrease in mortality associated with earlier whole blood transfusion was more pronounced among patients with higher shock severity. So we should improve our understanding of the physiologic reasons behind the improved outcomes associated with earlier whole blood transfusion. And of course, future studies are warranted to identify the effect of earlier whole blood transfusion on coagulation status of trauma patients. I'd like to thank my mentor, Dr. Joseph, and the Division of Trauma at University of Arizona for their constant support. Thank you.
Congratulations. This paper will be opened by Dr. Jason Smith from the University of Louisville.
Thank you. And I'd like to thank the association for the opportunity to discuss and thank the authors for a very well-written paper and a good presentation this morning. So obviously, understanding the use of whole blood in a civilian setting is one of the big questions that we're going to have moving forward, probably over the next decade. And it's not new. I think one of the things that we look at is the use of the military data that is coming out and how do we transition what the military has provided us over the last 2 years of their in-theater combat casualty evaluation, triage, and management, and how do we take the best of those lessons and apply it to a slightly different, if not completely different, civilian trauma setting for the management of those injuries. And so as that, I think the use of whole blood and the timing of whole blood is really one of the most important things that we're going to get out of probably this area of research. And so it's a very timely topic. I really have 3 questions. The first question is, and I will be playing a bit of its devil's advocate, is why do I need to give whole blood? I think you presented a very interesting topic this morning, but one of the groups that seems to be missing from this is a comparison of your evaluation groups to those that are getting just standard component blood therapy. And the reason I say that is if you look at the multi-million patient TQIP database where you were able to pull this from, you only were able to identify 1,953 patients that actually got it early. And I think that would be an important comparison group. So I'd love to hear your thoughts. Secondly, if I look at the delay groups for both over 30 minutes and over an hour, it seems to be that there's a higher incidence of a blunt mechanism and a higher incidence of falls in those groups. And in addition, if you look at the over 1 hour group, they were 4 times as likely to need some type of take back operation compared to the less than 30 minutes. And so is this simply a surrogate for not recognizing the early need for whole blood, i.e. you don't realize how injured they are until they get through the door because they may have a busted spleen and not a gunshot wound. And so is that a difference? And I think it's an important thing to look at because I do think that early whole blood will probably make a difference. And then finally, and I think you hit at this at the end, is that none of these groups showed a difference in transfusion requirements at 4 hours. And while we don't really understand the complete physiologic nature of why whole blood seems to be better than component therapy or reconstituted component therapy, one of the things that we postulated for a long time is that it would really impact coagulation. And by impacting coagulation, we then would see a decrease in many of the morbidity and mortality associated with hemorrhage. And yet you didn't seem to demonstrate that between these groups as far as a delay moving forward. Why do you think that is? And why maybe we should look for this difference in the future? Otherwise, I think it was a fantastic talk, a fantastic presentation, and it's a great a body of literature. I recommend everybody read the manuscript when it comes out.
Thank you so
much. Dan Margulies from Los Angeles. Just appreciate that study is really well done. One question is regarding the volume of blood given early on. So whole blood by itself is just bigger than the packed components. So I know at 4 hours, you said there was no difference, but if you're giving more volume early on, maybe you're resuscitating them better early on by using, 2 or 3 units of whole blood. It's going to be 1,500 cc's rather than, the components, which may go slower depending. So I wondered if you had any information on that.
Hi, Jordan Weinberg, Phoenix, Arizona. Very nice presentation. Thinking about the group of patients that got a whole blood in the 2nd hour, was that in general their first exposure to blood product at all, or were they getting maybe packed cells, FFP, or otherwise before that whole blood was opened up? And then also, did you look at time to operative intervention for hemorrhage control in these patients? Because maybe in the delayed group, they also had a delay relative to the early group in terms of hemorrhage control. So it might be an issue of confounding. Thank you.
John Santinello from Oak Lawn. I agreed with everything you said and what Dr. Smith said. My question is, since this was a large database study that we're seeing now, a lot of these questions that are being asked are really unanswerable. The question is, how do you decide who gets whole blood at your institution? Does everybody who needs a transfusion when they come through the door get whole blood, or is it just the people who are getting the massive transfusion protocols? Because I think that'll make a big difference, because like you said, you can't compare these outcomes to the people who just got the components separately, packed red blood cells, those other things. Yeah, thank you.
Excellent presentation. My name is Shrewsbury from New York. There's been some data to suggest that whole blood in the pre-hospital setting also results in decreased mortality. So my question is, were you able to account for the pre-hospital use of whole blood? Maybe it's in the PCR and TQIP. Thank you.
Hunter Moore from Colorado. That was a great talk and pretty interesting. It does seem to repeat history of early blood products are associated with decreased mortality. But the interesting thing is all the studies you put up weren't randomized controlled trials, and the 2 randomized controlled trials right now are still enrolling, and they haven't necessarily proven a definitive benefit. So it's assumed that this whole blood given early is making people more hemostatic, but there could be other factors, such as you have platelets that are cold stored rather than warm platelets. Have you guys looked at infectious complications and that as a potential cause of increased mortality?
Great. Thank you for all those questions. This paper will be closed by Dr. Bilal Joseph.
Thanks, everyone. I'll be quick since the presidential speech is next. But Dr. Smith, thank you very much for your first question. I do agree we should look at a subset of patients who are timed to any blood transfusion period. I think it is important. And it kind of answers Dr. Weinberg's question that all patients, that was their first transfused unit on presentation. I think that whole blood in itself, although no prospective randomized trials, the military data is pretty convincing, and all the data that's coming out of any observational study is showing some sort of benefit. As far as the second question, only 1 in 4 centers in the United States right now have whole blood on their shelves. And I think your point to, the patients who got it a little late, I think it's a variation. I think that they were under triaged. I mean, that's the easiest way to say it, which also maybe they were not recognized as sick. The penetrating were earlier, the falls and the blunt were later. So I think that could play in part to the overall outcome difference we saw, and it's a delay in overall care. And we know time to control is the most important thing. For your third question, the definition of MTP is changing. It's 10 and 24, or at the 6-hour time point, we had to use what TQIP had, which is the 4-hour time point, and 24. The 17 and 18 data actually showed a difference in overall transfusions, and all the other studies do the same. In our study, when you added all 3 groups together, we didn't necessarily see it at that time point. For Dr. Margoli's question about volume of blood, we don't have that in TQIP, but the unit of whole blood is only 500 cc's, which is less than the component therapies added together. So, but you get better bang for your buck. Dr. Weinberg, I mentioned that, yes, it was the first transfusion, and time to OR, we can figure that out and add it as a confounding. And then there was a question on how we do it in Tucson. If you come to the trauma bay, you get a unit of whole blood first until we go to MTP, and we have 6 units delivered twice a week. I'm happy to talk more offline for that. For Dr. Berry's question, we don't have pre-hospital data. And then Dr. Moore's point, I mean, this is intriguing, and I think there needs to be more, the TQIP gives us a high signal of what's happening to understand the real things going on at a national level. We really need to get further into the details of the data. Thank you for the committee and for everyone for allowing us to present today.
Great. Thank you very much, Dr. Joseph. Congratulations. So we're going to move right into the presidential address. You might stand up and stretch for a minute while we get Dr. Brazel's family in attendance, and looking very much forward to Dr. Brazel's address on the value of a sport.